there, and welcome to Elite Medical School. I'm joined by Dr. K and Mr. C. I'd like to begin by introducing myself, Dr. T. Today, we're going to start with a whirlwind tour of COPD exacerbation management. And this is going to help you on your wards, on your boards, and with saving lives. So pay attention because it's coming at you quick. Dr. K, why don't you start us off with a definition of COPD exacerbations and maybe the underlying illness. What's COPD? What's that even stand for, man?
Yeah, welcome everyone to the Wim Hof episode of the Elite Medical School podcast. So COPD characterized primarily by chronic bronchitis or emphysema or both. Basically, for those that have never heard of it, it's basically like breathing through a straw. It's a respiratory condition of non-reversible airway obstruction. And as Dr. T said, yes, it's very common. It's actually, I think it's the third most common cause of death in North America. So something you will certainly encounter.
Yeah.
And
if not suffer from. I mean, Mr. C, do you produce sputum most days?
Most days, yes, definitely.
Are you still hacking darts?
No, I stopped that.
Like most patients. Oh yeah, no, I've quit smoking.
I quit this morning.
Yeah, exactly.
the easy part is quitting. It's just it sucks that it's forever.
Yeah, it's a forever type of thing, non-reversible. So in terms of in terms of some other useful definitions, yeah, characterized by chronic inflammation. You divided to clinical subtypes there. So let's talk about the typical patient who's coming into your ambulatory clinic or your urgent care. So we got the 70-year-old lady. She's smoking a pack a day. She's bringing up sputum. She might be a little bit febrile. What do you think her vitals might look like? Why don't we start with you, Mr. C? What do you think is happening to her oxygenation, her heart rate, her respiratory rate?
I bet you her oxygenation is low. Her respiratory rate and her heart rate are high.
Yeah, you got that right. I mean, you got something right. Yeah, so indeed, those are important clinical markers there, and especially a long smoking history. So usually the COPD tends to develop after 20 plus pack years. That is a pack a day for 20 total years. So that's those are two sensitive markers there. Some other features of COPD exacerbation: presentation. Anything to add there, Dr. K?
I think the main symptoms that you'll be looking for would be you'd be following the Winnipeg criteria. So that's why we're worsening in dyspnea, that increased sputum production and sputum purulence. But when you go to see the patient, some other things that you will want to ask them about, you'll want to find out about the number of exacerbations that they have a year, when their last exacerbation was, maybe when they were first diagnosed with COPD. Have they ever had a requirement for the ICU from their COPD exacerbations? That smoking history is certainly very important. How long have they been smoking and whether they're still smoking now? I think it would be a good idea to get a review of their functional status, how many blocks can they walk typically and how they're managing at home. Like, are they using home oxygen? And then maybe to see whether their vaccinations are up to date.
Good. That's one that we often forget, right? Pneumovax in particular and Prevnar.
Yeah. Moderna.
Yeah. Moderna. Yeah. The Pfizer one So those are, and by the time this is released, that's probably not irrelevant. Yeah, and and some other features in terms of risk stratification. So, if indeed they have established COPD and have had prior episodes, they may have pulmonary function testing. The reason why that can be relevant is for folks that have FEV1 less than 50. It puts them into a higher risk category. So you might be more inclined to use more potent medications, and we'll talk about that in more detail. And we'll just touch base on that now. Less than 35% is considered a pseudomonal risk factor, and therefore you tend to use Cipro. But yeah, if indeed if the PFTs are available to us, then let's make use of them. Remembering that the COPD definition is obstructive, and it's the FEV1 over FVC less than 0.75. So that's a useful functional definition as well.
And if you keep following the GOLD criteria, you can rank the severity of the COPD. And as you said, 50% or less of FEV1 is very severe, and either that or whether the FEV1 is less than 30% predicted, that would also classify it as very severe. 30 to 50% FEV1 would be stage 3, severe. 50 to 80% predicted would be 2A, moderate, and then over 80% would be mild.
Right. Mr. C, any guess about what FEV1 might stand for as an acronym?
FED1?
FEE, like Edward V1. So Mr. C is our resident noob, and we just like torturing him with difficult trivia questions.
He's from a Caribbean medical school.
Yeah.
FEE1.
FEV1, forced expiratory volume within a second. So that's a good way to grade obstructive disease, and then using that denominator of your forced vital capacity is a way to sort of standardize it to your size. So obviously a tiny little lady might have a lower volume than a larger gentleman. So I think that's helpful in terms of a diagnosis. Your patient comes in, you have a sense of sort of what their background was like. You want to get a good sense if they're being adherent to puffers, like you said, whether they've had prior exacerbations, what they've needed for treatment, get a sense of how bad their dyspnea is.
On a physical exam, I guess, how would you assess for respiratory distress?
Yeah, so I think that's useful, and it's useful not only for COPD, but other presentations. So some signs of respiratory distress include tachypnea. That is, a respiratory rate, especially over 20, is worrisome. Like we said, desaturations, especially less than 90, and tachycardia, especially greater than 100. So those are some vitals. In terms of how the patient might present, tripoding, that is, that's something that I can actually do, but in a different way. But tripoding is a posture that dyspneic patients might assume, where they're resting their hands on knees in order to promote deeper breathing. So that's one presentation. Pursed lip breathing, that is sort of this, fish lips type of thing, pursed lip breathing. Tracheal tug, which would be an abnormal pulling just above the, what do you call that thing, sternal notch. What else do we have? We have paradoxical breathing, where you see the abdomen expand with breaths. You have intercostal indrawing. Intercostal indrawing, I would comment, is especially useful for people that are sort of like cachectic, and you can pick up on that. So those are all fairly good visual signs and vital signs. What about any oscillatory signs there, Mr. C or Dr. K? Anything you might hear?
Raspy voice.
Raspy voice. High sugar cube. I smoke a packet.